Welcome back to the deep dive. So you sent us some really interesting stuff this time, all focusing on prepping primary teeth for restoration.
Yeah, it's a fundamental topic in pediatric dentistry.
Absolutely. We've got video clips, some PDF notes.
Mhm.
Looks like they cover cavity prep, sealants, and those stainless steel crowns.
Right, the SSCs.
Exactly. So our mission today really is to pull out the key info for keeping these primary teeth vital and properly restored. And well, a huge part of that seems to be understanding just how different they are from permanent teeth.
That's the crucial starting point. The goal is the same, a healthy tooth, but getting there with primary teeth. It's a different path because their basic structure, their morphology, it's unique.
Okay, so let's unpack that. When you put a primary tooth next to a permanent one, what are the big, standout differences?
Well, first off, size and shape. It's obvious, right?
Yeah.
Primary teeth are smaller, but they're also more bulbous, more rounded.
Bulbous.
Yeah, and they have this pronounced cervical constriction, like they're pinched in near the gum line, much more so than permanent teeth.
Okay.
So what that means practically is you've got less tooth structure to work with. Your preparation has to be, well, more precise, less wiggle room.
Well, less wiggle room. Got it. And inside the tooth, what's different there?
The pulp. That's a big one. The nerve and blood vessel center. In primary teeth, proportionally, it's much larger compared to the tooth size.
Or pulp chamber.
Bigger and closer to the outside surface. Plus, the pulp horns those little points that reach up towards the cusps. They're longer and more, well, pointy.
Okay, I see where this is going.
Right. It makes hitting the pulp, accidentally exposing it during cavity prep, a much higher risk. So being conservative isn't just like a nice idea. It's absolutely essential.
Like navigating a minefield where the mines are closer to the top.
Exactly. That's a great analogy. Every touch of the drill has to consider that risk. It shifts your whole thinking from just removing decay to actively preserving what's left.
Wow, yeah. Definitely want to keep that nerve happy. What about the hard parts? The enamel and dentin.
They're different too. The enamel's thinner on primary teeth, and it's more uniform in thickness, actually.
Yeah.
The dentin underneath.
Yeah.
Also thinner. That's part of why primary teeth look whiter or more opaque sometimes.
But that thinner structure must make them weaker.
It does. More vulnerable to decay spreading fast and to fracture.
Oh.
So again, preparation has to be gentler. We really want to avoid weakening the tooth more than necessary.
So smaller, pulp, closer to the action, thinner protective layers. It all points towards needing a more delicate touch.
Precisely.
Okay, let's shift to the principles then. How do these differences guide how we actually work on these teeth?
Well, the absolute core principle, and the sources really hammer this home, is being conservative.
Right.
Only remove the decayed stuff, the curious tissue, keep as much healthy tooth as possible. One video showed a class I prep, right?
Yeah, the one on the chewing surface.
And it showed how they didn't just extend the preparation all over the place. They specifically avoided cutting too close to the cusp to protect it. That's the mindset.
Only what's needed. Makes sense. What else?
Rounded angles. Inside the cavity prep, you want smooth, rounded internal line angles.
Why is that?
Sharp angles create stress points. Think about it. Chewing forces concentrate there. That can lead to the tooth cracking or the filling fracturing later on.
Okay.
Rounded angles spread the stress out. Plus, the filling material adapts better, fits more snugly into those curves.
Good point. Anything else fundamental?
Generally, a flat pulpal floor is recommended. Again, avoiding sharp angles where the floor meets the walls. Less stress, more stability for the filling.
So, gentle decay removal, smooth internal curves, stable base. Got it. Now, let's get down to the actual preparation. How does it differ in practice from a permanent tooth, say a deep class 1?
Okay, deep class 1, the initial steps are pretty similar, actually. You've got to get rid of all that extensive decay.
Right.
Smooth back any enamel that's undermined, that doesn't have healthy dentin supporting it. Extend into any suspicious grooves, and make absolutely sure all the infected dentin is gone. That stuff is soft and full of bacteria. It has to go.
Standard procedure so far.
Yeah, but here's where the primary tooth difference kicks in. If it's a really deep cavity, but you haven't hit the pulp.
Fingers crossed.
Exactly.
Yeah.
You might place a biocompatible base material first, before the filling.
Like a liner.
Sort of, yeah, like an insulating layer. It protects that closer to the surface pulp from, hot and cold sensitivity, a little extra padding.
Makes perfect sense. A little thermal barrier. Okay, what about class 2s, the ones between the teeth?
Class 2s are interesting in primary teeth. If it's a very small early lesion with the ICCM lecture called A1 or A2.
Right, the international caries system.
Yeah, for those really incipient ones, the sources suggest maybe you don't need to drill right away. Maybe
Oh.
intensive fluoride, really focus on oral hygiene, try to get the tooth to remineralize itself. Resin infiltration was also mentioned.
What's that again?
It's like sealing off the microscopic pores in the early lesion with a flowable resin. Stop the decay from getting worse without actually drilling. Pretty minimally invasive.
So sometimes the best prep is no prep.
For those very early ones, potentially, yeah. But for your bigger, more established class 2, you need a traditional preparation.
Okay.
And here, you definitely have to open up the marginal ridge, that edge of the chewing surface.
Yeah.
And you absolutely must break contact with the tooth next door.
Why is breaking contact so crucial?
So you can get a matrix band around the tooth properly. That band creates the wall for your filling. If you don't break contact, you can't get the band seated right, and you end up with overhangs.
Ah, those nasty little ledges that trap plaque.
Exactly. Leads to recurrent decay. So it's this balance. Be conservative, but make sure you can actually place a good, well-sealed, well-contoured restoration.
Tricky balance. What about class 3? Between the front teeth.
Usually for small ones, a simple conventional prep with bonding materials works fine.
Okay.
But sometimes, especially on the back surface, the distal of primary canines, you might add a little dovetail shape into the trep on the chewing surface.
A dovetail. For what?
Retention, extra locking for the filling. Primary teeth, especially front ones, sometimes don't offer as much surface area for bonding, so that little mechanical lock helps keep things secure.
Ah, clever. So these little design features compensate for the differences. Let's just quickly recap those key differences for cavity prep that the source has highlighted.
Sure. 5 main things. 1, smaller size, bulbous shape means careful, minimal cutting.
Right.
2, larger superficial pulp demands extreme conservatism to avoid exposure.
Got it.
3, thinner enamel and dentin need gentle techniques, don't weaken the tooth.
Oh.
4, different reattention needs sometimes requires features like dovetails or locks, unlike permanent teeth prep.
Makes sense.
And 5, material choice matters. Fluoride-releasing materials like glass ionomer or resin-modified glass ionomer are often great because they bond well and, crucially, often let you do a less extensive preparation compared to, say, amalgam. Glass ionomer almost acts with the tooth.
Okay, that's a fantastic overview of the restorative side. But you know the old saying, prevention is better than cure, right?
Absolutely. Which brings us perfectly to pit and fissure sealants.
Yes, let's talk sealants.
Okay, key thing first. Sealants are preventative. They don't fix cavities that are already there in a big way. They prevent them.
By sealing off those grooves.
Exactly, those pits and fissures on the chewing surfaces. That's where most decay starts, primary and permanent teeth. One source also mentions sealing proximal areas just below the contact point sometimes too.
Interesting. So who's the ideal candidate for getting sealants?
Well, the main group is anyone at high risk for caries. Definitely kids and teenagers with a history of decay, maybe poor hygiene, limited dental access.
Standard.
But interestingly, adults too. If an adult is high risk, maybe due to medications causing dry mouth or just past history, sealants can be really beneficial. It's not just a kid thing anymore.
Good to know. What else?
Deep pits and fissures themselves are an indication, especially on newly erupted permanent molars. That video made a good point. Those new molars can be hard to keep totally dry.
Right, they're still coming in.
So a glass ionomer sealant might be better there sometimes because it tolerates a little moisture. And definitely primary molars with deep grooves, especially if the child is already high risk.
Seal off those hard-to-clean little valleys. Makes sense. Any other situations?
Yeah, a few more. They can be used to arrest really early, non-cavitated decay, those ICCM stage 1 or 2 lesions.
So stopping it before it really starts.
Exactly.
That.
Also, patients with special needs where hygiene might be challenging, sealants add extra protection.
Good application.
Orthodontic patients, braces make cleaning harder, risk goes up, sealants help protect those surfaces, and just the tooth shape itself. If a tooth has really deep, narrow, tortuous grooves that are just impossible to clean well, sealant's a good idea.
Okay. What about, say, a 35-year-old, deep fissures, but zero cavities ever?
Generally, no. If the risk is low, the benefit is minimal. Probably not indicated.
Gotcha. So when are they definitely not the right call? What are the contraindications?
Right. If there's obvious rampant decay already, you need fillings, not just sealants.
Makes sense.
If there are cavities between the teeth, interproximal lesions, sealants on the chewing surface won't fix that.
Okay.
Teeth with really shallow, smooth, easy to clean grooves in a low-risk person. Not needed.
Right.
And a big one, Patient cooperation. If you absolutely cannot keep the tooth isolated and dry.
Because of saliva.
Exactly. Saliva contamination is like the #1 enemy of sealant bonding. If the patient's uncooperative, you can't guarantee isolation, the sealant will likely fail. Better to wait. I remember wrestling with cotton rolls on one kid. It really highlights why isolation is everything.
Isolation is key. Okay, so we decide a sealant is needed, the patient's cooperative. Walk us through the procedure.
Okay. First, clean the tooth really well. Use a little rotating brush, get all the plaque out of the grooves.
Rep the surface.
Then isolation. Super critical. Rubber dam is the best, the gold standard, especially for multiple teeth. But cotton rolls, dry shields, high-volume suction, air, those can work too, especially for maybe just one tooth or a younger child.
Get it dry, keep it dry.
Exactly. Then you etch. Apply phosphoric acid gel to the pits and fissures, usually for about 20 seconds. This makes the enamel surface microscopically rough so the sealant can bond chemically.
Creates little anchors.
Perfect way to put it. Then, rinse really, really thoroughly, 20, maybe 40 seconds. Get all the acid off, dry the tooth again. It should look frosty white. That's your perfect etch.
Frosty white, got it.
Now, apply the sealant material. Can be chemically cured. Mix 2 parts, like some glass ionomers. Useful if moisture control is tough. Or, more commonly now, light cured. You apply the liquid resin, then zap it with the blue curing light to harden it.
Okay.
Then, super important, check the bite. Use articulating paper. If the sealant's too high, it'll interfere. You need to adjust it carefully.
Don't want them hitting high on the sealant.
No. And finally, remove any excess sealant that flowed where it shouldn't, usually with a slow speed round burr or a sharp hand instrument. The video was right. The most common failure is bad bonding, usually from saliva getting in there.
And crucially, like the video said, no high-speed drill, no cutting into the tooth structure itself, right? No physirectomy.
Exactly. 0 tooth removal. It's purely additive, sealing over the existing anatomy.
Got it. Okay, so that's prevention. But what if the damage is already significant? That's where stainless steel crowns come in, isn't it?
That's right, the SSCs, the beloved workhorse of pediatric dentistry.
Workhorse, I like that. They seem to be the go-to for teeth with more extensive problems.
They really are. They're incredibly durable, relatively easy to place compared to other full coverage options, and often the best bet for long-term success when a simple filling just won't cut it.
So when does a dentist reach for an SSC? What are the main indications?
Pretty broad, actually. Teeth with really extensive decay, maybe decay on multiple surfaces.
Okay.
Primary or even permanent teeth with developmental defects like enamel hypoplasia, Turner's tooth, amelogenesis imperfecta, where the enamel is just weak and needs full protection.
Makes sense.
Definitely after pulp therapy on primary teeth, pulpotomy or pulpectomy. An SSC gives the best seal and protection for those weakened teeth.
Ah, good point.
Fractured teeth from trauma, and even as anchors, abutments, for things like space maintainers or habit appliances.
Wow, versatile. Okay, so what's the actual process? How do you place one?
All right. Get the child numb, local anesthesia, rubber dam for isolation,
Standard start.
then proximal reduction. Using the high-speed drill to slice through the contact points with the teeth on either side,
Yeah.
you need to completely break that contact. The video really stressed this not reducing enough here is a super common error.
Gotta get clearance.
Exactly. Then, occlusal reduction. Take down the chewing surface about 1 millimeter, kind of following the tooth's natural shape.
Okay.
And just like with cavity prep, round off all sharp line angles and pone angles. Minimize stress.
Smooth it out.
Then, remove any remaining decay. If you happen to expose the pulp doing this,
Uh-oh.
then you do a pulpotomy right then and there.
Address the nerve issue. Okay, tooth is shaped, decay is gone. How do you pick the crown, make it fit?
Crown selection. This is key. SSCs come in sizes. The rule, as the video said, is pick the smallest crown that completely covers the prep and seats fully.
Smallest that fits.
Right, because the main way it stays on is by snapping over that cervical bulge, that constriction. It needs to grip that.
Mechanical retention.
Exactly. Then you check the height, the occlusogingival lengths, make sure it clears the bite, and extends just a tiny bit, half to 1 millimeter, under the gum line.
And you can trim it.
Yep, trim it with special curved scissors or a grinding stone if it's too long. And here's the really big difference from permanent crowns. No defined finish line. No shoulder, no chamfer. You're not prepping a ledge for it to sit on.
That is a huge difference. So it just fits over the natural contour, basically.
Pretty much, over the prepared contour. Then comes contouring the crown itself.
Bending the metal.
Yeah, with special pliers. Crown contouring pliers adapt the sides, buccal and lingual. curved beak pliers for the proximal areas, getting good contact, and then crown crimping pliers to really roll that cervical edge inwards so it snaps tightly around the neck of the tooth.
Get that snug fit.
That's the goal. The video warned against over-contouring, making it bulge out too much that just collects plaque.
Right.
You try it on one last time, should feel snug.
Yeah.
Often give a little click going on. Then smooth the very edge, the gingival margin, with the rubber wheel so it's not sharp under the gums. Cement it, usually with glass ionomer. Have the patient bite on a cotton roll or stick while it sets.
Sounds very technique sensitive, lots of steps. Are there variations? Different types?
There are. For front teeth, where looks matter more, you could do an open face SSC. You prep for the SSC, place it, then cut a window out of the front metal part. Then you bond tooth-colored composite filling material to the tooth inside that window. Looks better. Note, composite bonds to tooth, not the metal.
Ah, okay. A cosmetic fix.
Sort of. There are also direct resin crowns or strip crowns. Use a clear plastic tooth form, prep the tooth, pick the right size form, etch and bond the tooth, fill the form with composite, place it over the tooth, light cure, then peel off the plastic form and polish the composite.
Like building a whole new crown out of composite?
Essentially, yeah.
Mm.
And the video also mentioned prefab zirconia crowns. Newer option, more aesthetic than metal.
The white ceramic ones.
Right. Main difference there is they usually need more tooth reduction, especially occlusally, because the ceramic needs a certain thickness for strength.
Interesting. Good to have aesthetic options. Okay, back to SSCs. What are the common slip-ups? The errors to avoid?
Several big ones.
Yeah.
Not reducing enough between the teeth leads to poor fit, open contacts.
Right. The proximal reduction.
Taking too much off the chewing surface, crown ends up loose.
Okay.
Leaving sharp line angles on the trapped stress points,
Yeah.
risk of fracture.
Mm-hmm.
Poor crown fit overall, wrong size, bad contouring. Maybe it extends way too far into the gums or leaves gaps at the margin.
Margin gaps mean leakage. Yeah.
Exactly. Leakage, recurrent decay, and a huge one, not checking the bite before you cement. You cement it high, now the patient can't bite properly. Big problem.
Check occlusion first. Got it. Wow, this has been really thorough. So wrapping up, key takeaways seem to be: primary teeth need special handling due to their unique anatomy, smaller, thinner enamel, bigger pulp.
Right. Handle with care.
Prevention with sealants is huge, and not just for kids. Adults at high risk can benefit too.
Absolutely. Don't forget the adults.
And stainless steel crowns are a super reliable fix for bigger problems, fitting differently than permanent crowns, no formal finish line needed.
The workhorse. Reliable and durable.
And underlying it all is, be conservative, respect the pulp, choose the right materials. It's about keeping those primary teeth healthy until they're ready to go naturally.
Precisely. And, stepping back, these decisions, they seem small tooth by tooth, but they really add up. They impact the child's long-term oral health, their comfort, even their attitude towards dental care later in life.
That's a great point. Which leads us perfectly to our final thought for you, the listener. Considering how materials and techniques are always evolving, we mentioned zirconia, resin infiltration, how might our ways of restoring primary teeth keep changing? How can we push towards treatments that are even less invasive but just as effective, or even more so in the future?
It's a dynamic field, always adapting.
Definitely something to think about. We encourage you to keep exploring pediatric restorative dentistry. Understanding these foundations is key to promoting lifelong healthy smiles. Thanks for joining us on this deep dive.